Good morning, everyone. Ladies and gentlemen, esteemed guests and distinguished panelists, I'm honored to welcome you today to the event, The Landscape of Capacity Building in Global Health, held by the Global Health Institute at the American University of Beirut. Today, we are honored to have with us Dr. Zahir Dawi, the Provost of the American University of Beirut, Dr. Amar Mahmoud, the Senior Program Specialist at the International Development Research Center, and Dr. Shadi Saleh, the Founding Director of the Global Health Institute. My name is Nasreen Al-Hadi, and I am the Academy Division Manager at GHI. Our event will start with opening remarks from Dr. Dawi, followed by that of Dr. Saleh, and then Dr. Mahmoud. And then we're going to have two presentations about shedding the light on the innovative approaches taken to address capacity building in the Global South. Finally, we will engage in a moderated panel discussion with experts in the humanitarian field, offering diverse perspectives and invaluable insights on capacity building. Starting with the opening remarks, Dr. Dawi, the floor is yours.
Good morning. It's a pleasure to be with you today. And it's great to have AUB hosting this timely event led by our Global Health Institute. Capacity building and global health are two central themes that our region and the broader Global South are in utmost need for. Our region is currently in a state of disarray, uprisings, conflicts, wars, and genocides, leading to forced migration and displacement, coupled with corruption, economic instability, leading to injustice, immigration, and societal challenges. And these are affecting large segments of the populations. Global health is thus essential for promoting human rights, achieving sustainable development goals, and building a healthier, safer, and more inclusive world. We at the American University of Beirut are strong believers that global health interventions must be contextualized and must originate from within and around the communities they aim to serve. This is the only path forward towards real impact, effective and sustainable impact. How to contextualize global health knowledge, global health practice and policy, how to connect and exchange globally, but yet also act and shape locally. These are questions that are at the core of our Global Health Institute's mission and vision. The foundation for addressing these questions and many others lies in the human capital, the driving force behind any development, innovation, and advancement. Hence, it comes as no surprise that GHI is convening this esteemed group today at AUB to talk about capacity building. It's about empowerment and strengthening. It's about resilience and building. Accordingly, the questions become, who to train when you talk about capacity building? Should we focus on the citizens and community members, health practitioners and frontliners, or maybe the trainers and experts? What content to offer? Should it be basic, advanced, general, or specialized, discipline-specific, or personal skills, and with local or global focus? Which modalities and pedagogies to adopt, and how to know whether the offerings are meeting the set quality indicators and targets? How to assess the impact of capacity building programs, and how to learn from each other, sharing experiences and refining plans. I will leave it to our GHI director, Dr. Shadi Saleh, and his capable team, together with the partners who are here today, to lead the way and through presentations and panels to shed light on some of the above questions and to engage the audience in thought-provoking conversations and insightful discussions. Thank you, and I'm looking forward to being with you for part of this day. All the best. Thank you.
Good morning, everyone. Sabah al-khair. I will be very brief because most of the points have already been covered by Provost Dawi. I want to thank you for being here this morning. I want to thank our partners for their belief in us and the long-standing partnerships that we have, whether it is with IDRC or with INFNET, Dr. Nassour and his team, with UN agencies and definitely faculties and units, other faculties and units within AUB. Yesterday I was browsing the social media and I found that there is a keynote speech by a professor and or an expert, and I cannot remember the university, but the title of the speech was Building Capacity in Global Health in Conflict Settings. The person who was giving, the expert who was giving the speech has never left the global north, right? So the first thing that came to my mind is how can this person, with all due respect, talk about global health capacity building or global health in conflict settings, and they have never experienced it either as a person living in that part of the region or as a person who has practiced, who has worked in that part of the region. And I go to my starting point, which is one of the main reasons that AUB started the Global Health Institute, is to contextualize the global health, to be part of that dialogue, to provide our perspective, specifically when it comes to capacity building, research, service, and practice. And this is what we have tried to do over the past few years. So the main reason why we elected to offer this or to hold this meeting today is to shed light on the importance of contextualizing any global health discussion. We, in this part of the world, cannot be more royal than the king when it comes to issues that the Latin America region faces or the Africa region faces. But at the same token, we in the global south know better about our challenges than folks who are in universities, research centers, training centers in the global north who do not experience or have the lived experiences of what is faced in the global south. So again, I'm not saying this to have a negative spin on all of this, but rather to highlight how important it is to have these discussions, to have us as global health and public health professionals talk about our experiences, our offerings, and engage more and more in the global discussion on health in general. Again, I would like to thank all of you for being here today, and I look forward to a very fruitful discussion with all of you. Thank you.
Dr. Amar, the floor is yours.
Good morning. Can you hear me?
Yes.
Okay. Hi, everyone. Good morning. Bonjour. Sabah al-khair, sabah al-noor. I am very delighted. My name is Kamar Mahmood, and I'm very delighted to be part of this this event, this webinar that American University of Beirut has organized. And following on the points raised in these opening remarks by Dr. Dawi and Dr. Saleh, I would like to say that we at IDRC, Canada's International Development Research Center, have been supporting Global South evidence generation and research, both research, conducting of research, but also capacities in developing those research capacities throughout the Global South. And we are very proud that we've been working over several years with the American University of Beirut, which has been a key partner for us, not only in the region, but through the GHI, Global Health Institute, really taking the leadership to another level, this leadership at the Global South level. IDRC, just for those who are not as much aware of our work, is Canada's one of Canada's funding agencies that supports research and evidence generation in lower and middle income countries. And we've been doing it for over 50 years now. The IDRC came into existence in 1970 through an act of the Parliament of Canada. Our footprint has been much more prominent in Africa historically, but over the last decade, especially, we've been much more involved in the Middle East and North Africa. I am based in our Middle East and North Africa office, which is in Amman, Jordan, and but our engagement through AUB and newer partners like MFNET has been going on for several years now. What IDRC basically supports is not just evidence generation, but also capacities, as I mentioned before, but also leadership, both for emerging and established leaders in the global South. And another key element of our support is through partnerships. And as you saw mentioned in the opening remarks, that all three of those elements are reflected in this, will be reflected in this event today. Because AUB has been and GHI has been quite a key player in all three of these areas of support. I am with the Global Health Program at IDRC, and Global Health Program, while the focus changes over time, like based on our the needs that are there at the time. But one of the key elements has been, or consistently a key element for us has been support on health system strengthening. And key within that, a critical area within that is, as was mentioned, the health workforce. Because health workforce is a very critical element that there's a need to support that. Obviously, in fragile context that MENA is experiencing and has been over the years, is very challenging. And I think this event and the panel and the discussions, I look forward to hearing experts talk about how do we address those challenges through some innovative solutions as well. Thank you so much, and I'm looking forward to hearing the panelists and all the presenters at this event today.
Thank you very much. Thank you very much. Thank you, Dr. Saleh. Thank you, Dr. Dawi. We will move to the presentations now. And I will start by the first presentation, where I will talk about how we at the Global Health Institute are empowering the Global South through capacity building. And particularly, this is through our Academy division. So the Academy was launched in November 2017, and it aimed to address the critical capacity building needs that the Global South faces. We started first by recognizing the capacity building challenges that our region faces, such as conflict settings that lead to security issues hindering in-person training, to limited context-specific resources and experts, as well as funding constraints directed to capacity building, among many others. These challenges not only negatively impact the population health outcomes, but also strain national health systems. And so the division goal is to cultivate local leadership and contextualize knowledge and tools to tackle the global health challenges effectively. This is through our innovative portfolio. We offer capacity building offerings as online asynchronous courses, certificates, and diplomas. And this is through our own online learning platform, the Global Health Learning and Development Platform that we refer to as GLAD. Also, we host the Center for Research and Education in the Ecology of War that we call CREW. CREW is a remote mentored fellowship program, and it develops the research capacity of healthcare practitioners in conflict settings. Next, we have one of our flagship initiatives, the Mobile University for Health that we call MUH. MUH develops the capacity of vulnerable men and women in their communities. And finally, not only do we provide all of these initiatives, but also we evaluate them through our own evaluation of capacity building program that we call ECAP. And we will be reporting on the results of ECAP later on today. Moving now to the online capacity building offerings, we provide these in 3 different sectors. The first sector is the humanitarian sector, and this is where we offer the Humanitarian Leadership Diploma that we call HLD. HLD aims to build the capacity of the humanitarian workforce, equipping them with the leadership skills to become agents of change. And this is through 8 online self-paced courses on our own online learning platform, GLAD. The second sector is the health and conflict sector, and this is where we offer the certificate in conflict medicine that we call CCM. CCM aims to empower healthcare practitioners by advancing their skills in conducting research and delivering medical care that is contextualized to the settings of conflict and fragility. It is a 4-course certificate where 3 courses are core courses and 1 is an elective, where a learner can choose 1 out of 3 topics. The last sector is the civil society sector, and this is where we offer a variety of organizational development courses in 3 different languages. All of these are on our own Global Health Learning and Development platform, GLAD. GLAD provides 40 offerings across the 3 sectors that I just talked about, and we have reached currently over 2,800 registrants from 32 different countries, such as Lebanon, Palestine, Jordan, Egypt, Morocco, Tunis, Turkey, among many others. Next, we move to the Center for Research and Education in the Ecology of War, CREW. We established CREW because we believe at GHI that in conflict settings, there is a need to harness the field-based experiences of those working on the ground and translate them into research outputs in order to mitigate the knowledge lost in this setting. And hence, we established CREW, that is a remote mentored fellowship program, and that aims to strengthen the humanitarian practice in conflict setting through contextualized research and tailored capacity building of frontline health practitioners. Every year, CREW has a particular topic. Over the past couple of years, we had one on antimicrobial resistance, another one on cancer research, and currently we are launching the preparedness for the impact of climate change on health. CREW has reached 9 fellows from 6 different countries, such as Lebanon, Jordan, Syria, among others. Next, we move to one of our flagship initiatives, the Mobile University of Health, that we developed at GHI to compensate for the lost educational opportunities that vulnerable refugees face as a result of conflict and displacement. Through MUH, we aim to equip women and men with the health knowledge to serve as community health workers in their respective countries and to support, upon graduation, their access to healthcare, helping them rebuild the healthcare system. MUH is structured in 2 components: a capacity building component, where we offer 4 certificates on key health topics, and where we empower women and men to become community health workers, and a community of practice component, where GHI identifies community health workers who did well in the capacity building component and supports them in leading formal and informal health conversations in their community. This bridges the gap between the formal healthcare system and the community. And through COP, which is the community of practice, GHI creates a support system for those community health workers that includes continuing education and a network for future work opportunities. To date, we have reached over 120 graduates who have received various healthcare certificates from us, and we have led over 45 community-based health awareness and promotion days, covering over 52 different health-related topics. This brings us to the end of this presentation, and I will leave the floor to my colleague, Hadi. The floor is yours.
Good morning, everyone. Thank you for joining us today. My name is Hadi Naal. I am the Programs Division Manager at GHI. Building on Nisreen's presentation and on the fact that there is a noticeable scarcity on research guiding the best practices for designing, implementing, and evaluating innovative learning modalities for capacity building, we incepted ECAP as a 5-year project that aims to assess the use of innovative learning modalities in global health capacity building initiatives in fragile and conflict-affected settings. So ECAP stands for Evaluation of Capacity Building. So we launched this project almost 5 years ago, and now we're nearing the end of it. So as you can imagine, there's a lot to unpack here, but I'll do my best to be concise. So basically, the work of the Academy provided a unique opportunity to conduct this project because, as Nisreen just mentioned, the capacity building initiatives of the Academy were designed to employ a range of modalities, so in-person, online, and blended modalities. And they focus on key populations within the health workforce. So community health workers, frontline health workers, and humanitarian workers. And also they're conducted across, the operations are conducted across conflict-affected settings in the MENA region. So with this, our ultimate goal was to produce the needed knowledge to guide programming and best practices, and thereby optimize the use of innovative learning modalities in capacity building. And we did that not just to inform the work of the Academy, but also to inform the larger professional communities who operate in those settings of fragility. So to do so, we underwent 3 sequential phases, and we're currently in the last phase of the project. So basically in phase 1, we conducted a situational assessment based on 3 systematic reviews to have a better understanding of the landscape of capacity building, to understand how innovative learning modalities are being used and to what extent are they being used, and also to examine the evaluation methods that were used to evaluate them. Then in phase 2, and then as informed by the findings of phase 1, we would develop a monitoring and evaluation approach to then apply it to evaluate those capacity building initiatives of GHI by producing multiple case studies. And then finally in phase 3, we would synthesize all these findings and all this knowledge into the development of a framework to guide best practices in global health capacity building in fragile settings. And this would ultimately serve researchers and practitioners. So far we've published our outputs basically in peer-reviewed journals, with the exception of those under phase 3, which we're currently working on. So in the coming slides, I will walk you through some of our high-level findings without going into much details regarding each study for the sake of time. But I would encourage you to go through our publications if you want more details, and I'm also happy to take questions at the end. So in phase 1, we conducted 3 systematic reviews where we looked at approaches that are commonly used to evaluate global health capacity building initiatives. We mapped all global health capacity building initiatives that were conducted in the MENA region to examine their characteristics. And we also focused specifically on capacity building initiatives that targeted building capacity in health research. In short, we found that there was no standardization in how professionals were evaluating their capacity building initiatives, and that was especially regarding the tools. So there was a lot of discrepancy in how people were evaluating initiatives. And this was particularly true for innovative approaches, such as, so when we talk about innovative approaches, we're talking about online and blended programs, be them synchronous or asynchronous. And also they were not very common, not as much as in-person approaches. We also found that most initiatives tended to conduct their evaluations at the individual level of the learner and for a short period of time. So the problem here is that this would not, in most cases, it would not tell us much about the impact of these initiatives, especially when we want to look at the transfer of this knowledge to the organizations and the communities. We also found that there was a scarcity in the targeting of community health workers. So, and this group in specific is very important in our region and in context of fragility as a key health workforce group. And finally, we found a scarcity in approaches that focused on using interactive approaches in their delivery. Most capacity building initiatives used a theoretical, pedagogical approach. And it's important to be more interactive in the way that we do capacity building so that we can capitalize on active learning and to maximize engagement. So based on these findings, again, this is phase one, we saw an opportunity to develop and to test a standardized mixed methods approach and to also test standardized data collection tools that we would incorporate throughout the capacity building initiatives of the Academy. And we also integrated our work with the work of the Academy. So the idea was that this plan would allow us to produce the needed research so that we can later on develop a comprehensive framework based on this evidence. Okay, so moving on to phase two, and just to give you a quick reminder about the Academy's capacity building initiatives, we worked through MUH, which targeted community health workers through a blended learning approach, HLD, which targeted the humanitarian workers through online asynchronous modality, CREW, targeting frontline health professionals through remote mentorship, and NGOI, which also targeted humanitarian workers through in-person and online training. And we also based our evaluation approach on the Kirkpatrick model for evaluating trainings, whereby we would examine impact at 4 levels. So at the level of reaction, so looking at things like satisfaction with the trainings, etc. Learning, so knowledge changes, behaviors, so skills, practices, and results, so looking at the larger impact on the communities and the organizations where this transfer would be, where this knowledge would be transferred. And we also collected data from over 450 learners who participated in our capacity building initiatives, and from over 220 community members and members of the organizations that the learners are affiliated with. And we also used different tools that we had developed based on the results of phase one to be able to capture those different levels and experiences. So we used quantitative tools such as knowledge assessments, course evaluation, surveys, satisfaction surveys, and organizational surveys. And we used qualitative tools such as semi-structured interviews and focus group discussions. Some of these tools were administered pre and post, others at the 3 months post-intervention, and others at 6 months post-intervention. So because each case study has been reported on its own and on its own paper, I will just discuss overall results, high-level findings, and then those specific to online and in-person modalities. In general, across all initiatives, we found that GHI's offerings increased access to education because we capitalized on innovative ways to improve access. The initiatives also improved knowledge and skills across the targeted populations, and importantly, they empowered learners to develop professionally. So we saw that they had more credentials, credibility within their organizations and communities, and they also had increased skills and specifically leadership skills. And finally, we also found that GHI's initiatives were largely contextualized and relevant to the needs of the targeted groups. So going into a bit more details regarding the online modalities in specific, we were able to reach a large and diverse group of learners from across multiple countries. They were also largely accessible, and they allowed a lot of flexibility. And this is important because this allowed us to overcome traditional barriers that are associated with accessing global health education and humanitarian education, since it allowed busy professionals to be able to participate in those courses at their own pace. The most important challenges were associated with learner engagement, which also tends to have an impact on their commitment levels. This was especially true in asynchronous modalities, and it's a commonly reported challenge in the literature, which we accounted for in our approach. So, for example, we made sure to have an open door policy to allow instructors and learners to interact with each other. We also provided platforms for discussion forums to encourage peer interactions. And we also maintained regular contact with the learners throughout this journey. So these strategies helped us to maintain engagement with the learners. There was also the problem, not surprisingly, of electricity cuts, weak internet connection, and other factors associated with weak infrastructure. However, this was not a significant barrier because asynchronous modalities are not contingent upon these schedules, so the courses could be taken at the learner's own pace. So we're reaching the end. As for the in-person modalities, they were mostly favored by the learners because they allowed for real-time interaction and engagement. However, they also presented their own sets of challenges, such as the need for transportation, prioritizing commitments, and so on. So one major limitation in the work that we did is that we mostly relied on qualitative approaches and that we did not directly quantify improvements in health outcomes. But this was because it's beyond the scope of the project, and maybe we'll be able to do that at a later stage. So finally, in phase 3, we're currently working on synthesizing all of this knowledge that we produced throughout those 5 years into the formation of a framework to inform and guide capacity building initiatives in fragile contexts that focus specifically on innovative approaches, which we will later disseminate once finalized. Thank you very much for your attention, and happy to take questions.
Thank you, everyone. We're going to open the floor for questions from the audience, in case you have any. Yes.
I'm just curious about the long-term evaluation, because as you mentioned, you focused a lot on short-term, up to 6 months post taking the certificate or the course. But sometimes the real added value of that education, one would see maybe a year or 2 years ahead. Do you have plans to extend beyond the 6-month period, or that's kind of quite complicated to track them individuals?
Yeah, thank you for the question. It's obviously a very important question to examine long-term impact. So ECAP is a rolling project, so we can always reach out to the learners who attended our initiatives. But the problem is that, especially when we consider the context that we live in, it's very difficult to maintain regular contact with the participants because it's a context of fragility and conflict. It's very likely, especially when it comes to community health workers, for example, it's very likely that they will probably migrate to other areas, or something would happen that would not allow us to be able to get in contact with them. So yeah.
Thank you. Thank you so much for the presentation. My name is Yara Al-Musawi. I work on infodemic management, country lead support with WHO Afro. I'm very, very happy with all of the presentation because this is something that I was very much looking forward to ask about and to know more about, which is the post-assessment, the M&E, the monitoring. So what I do is that I work on infodemic management with French-speaking countries and English-speaking countries on strengthening their infodemic management systems with ministries, with country offices. But what I encounter and what I it's something that is very common, is that whenever we talk about capacity building activities, everyone is very, very interested and is very excited. Trainings, travel, new knowledge, new skills. But whenever we want to talk about post-assessment, monitoring, what are we going to do after this amazing workshop, we always face a lot of, resistance, and also a lot of questions. Okay, and we did this capacity building, we got the knowledge, let's assess this after, let's discuss the M&D after. So I have two questions for you. When do you talk about the M&E? When do you talk about post-assessment? Is it when you are already talking about the workshop, the initial planning, and what is the behavior of people? What is their attitude when you are suggesting activities for post-assessment? The second one, can you please give us some case studies, some examples? The differentiation between online and offline is brilliant, it's very good. But can you give me, please, some examples on things that you have encountered within your offline and face-to-face workshops and trainings in monitoring, especially within the MENA region, because this will be very interesting for me. Thank you.
Okay. Thank you for your question. So I'll start with the first question. So this is a problem that is, I think, every researcher faces, especially when it comes to capacity building initiatives. Usually people are not interested to waste their time, but to dedicate some time to answering these questions, especially when it comes to post-intervention and follow-ups. And we considered that this was going to be a problem that we were going to face. And for this reason, we made sure, because the learners, there's a lot of interaction between us and the learners. So there was, so basically we had the opportunity to develop a relationship with them from the start. So when they first sign up, to, for example, the online offerings or the rest of the in-person capacity building initiatives, we would explain to them when they first sign up about ECAP and about the importance of having their feedback so that we can better serve them and other learners in the future. So we basically explained to them the importance of this data that we would collect from them. And that was one way of bringing them closer to us in terms of engaging them to get this data from them. The main problem was in the long-term follow-ups, as a follow-up to Dr. Dawi's question. That was our main problem, to be able to get this follow-up data on the long term. But what helped us is that we also tended to work, for example, in the MUH case, we tended to work through also implementing partners in those different contexts, where they would also facilitate establishing contact with them, especially when it comes to long-term data collection. Can I ask you to please repeat the second question?
If you have any examples,
yes.
Case studies,
yes.
from offline face-to-face post-assessment that you have done within the MENA region, and you've done a training here in AUB for 3 days. How do you post-assess the impact of this training? I know that you gave example after 6 months.
Yeah.
After a brief time, but if you can give us some examples.
Yeah. Yeah, so here, and this is again the value of the framework, it depends on the type of initiative that we're evaluating, and it also depends on the modality that we used to deliver this capacity building initiative. So for example, in HLD, because it's a purely online asynchronous approach, we relied on sending out surveys to get this data, and we also, because again we were in touch with them, we were in contact with them, we were able to ask them to have a phone interview, for example, to collect qualitative data. But in the case of MUH, which is a blended, which followed a blended modality, we went to the field through through the NGOs that were partnering with us. And we gathered them there to be able to collect this data from them. Okay.
Good morning, everyone, and thank you so much for this presentation. It's really interesting. I'm Antoine Hreiki, Social and Behavior Change Officer from UNICEF Lebanon. I just have a few questions regarding the trainings for the community health workers as part of on the community engagement, mobilization, and let's say interpersonal communication skills. And your post-evaluation of this training program, how did these trained, let's say, practitioners or community health workers were able to successfully engage with communities, understand them, because part of their work is changing behaviors, and it's more than awareness. So it's how we communicate with them, how we make communities to participate in the same work as we do. So I'd like to see on this aspect, how did these community health workers train? Did they find the training programs good? What was the gaps might be, and what could be improved? Because as we know, community health workers training in Lebanon is not standardized, like for example in Iraq and Jordan, other areas. It's not fully under the MOPH umbrella. So how did these trained community health workers in their long-term employment opportunities, did they continue with it? Did they migrate to another sector, to another industry, or khalas, they did this training and they were not able to find any job opportunities or long-term one? And how do you see as well as GHI the way to standardize community health workers in Lebanon? Because as we know, there are many NGOs, many partners, many actors giving these training programs. We see booklets, we see manuals, but nothing is standardized in Lebanon. So there's no standard certificate, there's no anything. So is there anything as GHI, as part of the advocacy part, if I may say, you're working on this, let's say with MOPH, with the health sector, with UNICEF on? Thank you so much.
Yeah, thank you. Very, very important questions. And I think here, we can shift our focus to MUH specifically. So basically, what we did, or basically the results that we found through our evaluation. So, and we implemented MUH over a period of 4 years, and we were regularly collecting data from the different cohorts that participated in it. So the main things that we found in response to your question is that MUH improved significantly the credibility and the leadership skills of the community health workers who participated in MUH. So, so basically what happened is that those community health workers, as soon as they graduated from MUH, they had 2 channels where they could interact with the rest of the community. One channel is informal, okay, so that means through discussions with their immediate networks, because they participate, they learn new things, and then they go and they disseminate this information within their families. And there's a lot of details in the publications regarding that. But also there was a formal opportunity for them to disseminate this information through the community of practice, COP. So the COPs were basically health awareness events that were led by the community health workers. So, so we supported them in coordinating and with logistics, but they were the ones who were disseminating and promoting health and related health behaviors. So as you can imagine, within those communities, that gave them a lot of additional credibility and empowered them to disseminate this information. And also this will cascade across the community, across members of the community. Yeah. So, yeah. Mm-hmm. So, yeah.
Just to standardize these packages, because as we know, it's in Lebanon we don't have it under MOPH. Let's say like in Iraq and Jordan, where it's fully like you get certificate by MOPH, there's a TOR, there's standardized. We see many actors, many organizations, many institutes do trainings for community health workers. Is there anything as GHI, you're working as an advocacy part to mainstream, let's say, the same content among everyone, to standardize these training packages under, let's say, the leadership of MOPH, or are you planning anything like that, just to make this knowledge, let's say, standard? If a community health worker was trained, let's say, by an ex-NGO, it would be the same as by the other institute under, let's say, MOPH or UN agencies or anything like that. If you have anything like in mind as GHI.
Yeah, so currently we're working towards scaling the work that we're doing in MUH so that we can reach more communities across Lebanon and the region. In terms of our advocacy work, currently what we're doing is we are, disseminating this information. We are, disseminating the findings of MUH. Where, as part of this event is to do this advocacy work that you're talking about, and we could consider in the future, doing this standardized licensing as you're mentioning.
If I may, it will be extremely challenging to standardize capacity building, right? Yani absent an authoritarian regime, which we may need, but absent that, it will be very, very challenging to systemize how capacity building is done at so many levels, except within organizations, right? Like in the UN, you can do it because there's a university for the UN that can provide UN agencies with a standardized approach to capacity building. So you can do that. Within the Ministry of Health, you can do that because there's obviously an umbrella organization. But across the border, it will be very challenging to do.
Okay.
Any other questions?
Thank you very much.
Thank you. Okay, thank you everyone. We will proceed with our moderated panel discussion. And the moderator for this session is Dr. Tanya Haddad. She's an associate professor of public administration at the American University of Beirut and the director of the Global Engagement Initiative. Her research focus is on civil society and social justice, nonprofit management, volunteering, disaster management, and e-government. Dr. Haddad is going to introduce the panel and then lead the discussion. Thank you, Dr. Haddad.
Thank you, Nisreen. Thank you, Nisreen. Thank you, Dr. Saleh and GHI for inviting me to be part of this panel. The way we're going to proceed, we're going to have like 45-minute discussion, and then we're going to open the floor for Q&A. We're going to start with a small introduction. So the region has long history of dealing with complex emergencies, including conflicts, large-scale human displacements, and political and economic instabilities. The impact of armed conflict on population health outcomes and national health system has been devastating. Indeed, in conflict settings, the humanitarian system struggles with inadequate resources to address health issues impacting affected populations. Healthcare professionals in these settings encounter numerous challenges when it comes to advancing and refining their professional and leadership skills. Challenges include lack of time to take off work, difficulty in conducting in-person training, insufficient funding for professional development. What are the lessons learned from global health capacity building? How can we implement innovative learning modalities in fragile environments? What collaborations are essential for capacity building? How do we measure and evaluate impact for sustainability? What strategies are effective for financial and resource mobilization for capacity? And what are the considerations for mental health in capacity building? Our esteemed guests today will be tackling these questions and will share with us their insights on the topic. We have with us on the panel today Dr. Muhannad Al-Mansour. Dr. Mansour is the Executive Director of Global Health Development at Eastern Mediterranean Public Health Network and founder of the International Academy of Public Health. Dr. Mansour served as consultant for esteemed organizations such as the CDC, WHO, and AUB. We also have online with us Dr. Simona Costanzo So. Dr. So is the Chief of Academic Partnership at the United Nations System Staff College. She has a track record in capacity building, non-formal education, learning and training, as well as community empowerment and stakeholder engagement. We also have Dr. Arash Rashidian. Professor Rashidian has an established career in health policy and systems development in different countries. He is the Director of Science, Information, and Dissemination in the WHO Regional Office for Eastern Mediterranean. He is the Vice Chair of WHO's Guideline Review Committee. We have with us as well Dr. Zinia Sultana. Dr. Sultana brings over 15 years of invaluable and transformative experience to discussion as a distinguished senior public health officer with the UNHCR. With a Master of Science in International Health and a Diploma in Tropical Medicine and Public Health, Dr. Sultana's expertise lies at the intersection of dynamic public health and challenging humanitarian crisis. As a panelist, Dr. Sultana brings a wealth of first-hand experience in navigating the complexities of capacity building within the context of formidable humanitarian emergencies. We have Dr. Tanya Boski. Dr. Boski is a clinical psychologist and assistant professor at AUB and the Trinity Center for Global Health. She is a specialist in child and adolescent mental health during adversity and has clinical experience in Northern Ireland, Palestine, and Lebanon. Thank you for being with us today. Dr. Mohammed Mansour, I'll start with you today, and we'll start with understanding the health capacity building in fragile contexts. How do you see and how do we really address the needs of low to middle income communities in capacity building initiatives?
Thank you very much and good morning. And allow me first to thank GHI for this kind invitation to be part of this important session. Thank you, AUB as always, and thank you, Dr. Saleh and colleagues. So if you allow me just in a few words before going to the fragile settings, to describe the current health workforce over the world, that this is a global problem and we are part of it. So health work has become a major concern and a health policy issue around the world. And if we remember that health workforce was the focus of the World Health Report in 2006. So we have this problem at a global level before going to that. Of course, for in any health system, the totality of the workforce is essentially leading and providing health care in pursuit of improving population health. We keep talking about universal health coverage and achieving the sustainable development goals, but the workforce is the cornerstone for achieving these targeted or going through these things. Of course, when we come to our region, it's became more difficult situation, even worse than the southern part discussion. So we have northern part, southern part, but we have our region with the complexity of, as colleagues mentioned, instability, insecurity, wars, displacement, political instability. All these, makes our region is very fragile. And we just, in the past decades, we witnessed in Iraq, in Yemen, in other countries, nowadays we are witnessing the instability and the critical situation in Gaza and in Sudan. So back to the, in brief, about the statistics that the need was estimated at over 4 million in 2013 and projected to be 6 million in 2030. So there is a huge gap, and it's a result of a brain drain of qualified health workforce out of the region. This is the main, defined reason for that. So if we really plan to achieve, and to SDGs, and we will continue this discussion, we need to invest, more in workforce and to focus in our, etc. So this is in general, and I think, that situation is becoming more critical in our region, and we need seriously to start thinking how we can better invest in the workforce, and in general, how we can, as Dr. Shadi mentioned, how we can customize or, conceptualize the concept of workforce within instability of our region and or this special situation. So this is in brief, and you know, we can later, but again, you know, we cannot keep, you know, just you know, copy paste from other regions. We need to create our case. You know, as I remember, you know, 20 years ago, we were teaching the case studies, you know, only from USA and UK, and which is really very far away from what we are facing. So I was in Yemen, and I remember there was a case study about blueberry, raspberry. So we spend a lot of time just to explain blueberry, raspberry, but the situation was totally different. So we need to customize all our trainings. We need to see the best approaches to make this. So within this context, I think even became more difficult with the emergency led witness and how we can make any of these initiatives are more sustainable and valid. You know, and I would like to bring field epidemiology training programs as example where there was a huge investment within the Ministries of Health in building the capacity of the country in the field of epidemiology, where our professionals could, you know, support their ministries and countries, you know, in investigating, preparing, responding to any, you know, public health crisis, and it's a national capacity. In the past 2 decades, the region was somehow relying on external assistance. But, you know, usually there was external deployment, assistance, you know, support when we have a crisis. But again, you know, with the current situation in the region, nobody was deployed in the past 10 years. Mainly, you know, it was very difficult situation. So the investment within the country is a critical point that we need to follow. And when COVID-19 came, you know, it was very difficult for the international cooperation. So the only way was, you know, to focus on the national capacity. So the pyramid before that, it was somehow it's upside down, where it was the main investments comes from the global region and country level. Nowadays, we are trying, you know, to build vice versa from the bottom to the top, you know, by investing in the national capacity, then moving to the regional approach. And of course, you know, we are part of the globe and we are part of the global health security of the world. So this is in brief, and I'm happy, you know, to add or comment whatever.
Thank you. Thank you, Dr. Mansour. Dr. Sultana, Dr. Mansour discussed the importance of really not having a ready-made solution or bringing a solution and then applying it to the region. He also discussed that there are going to be more than 6 million in 2030, so the need is really high. Based on your, as the head of the public health unit at the UNHCR, what are the challenges do you encounter in addressing the specific needs of vulnerable populations, especially in capacity building initiatives?
Thank you for the question, and good morning, everyone. I hope you hear me well. Yeah. So I think I will take the last point that you have mentioned about the challenges and the resources needed. My experience that goes beyond this region, so I would also like to complement with the other part of the global south, which includes Africa and Asia, where we often see that during these conflict-affected situations or fragile situations, the resources are more directed towards immediate life-saving emergencies rather than capacity building. Even if capacity building initiative is there, there's not enough time to invest on that, which could be relied upon later. So I see here these challenges related to how to prioritize the resources, which are getting decreased over years, as we all know, in terms of humanitarian support. And in that regard, I think what the doctor said is also important, that how best the national system could be relied upon so that any emergencies could be tackled by the local system itself. Now, particularly focusing more into the vulnerable population, since I come from the refugee agency, I could also bring some, shed some light on that in terms of what we see in the other part, which has the added component of challenges for capacity building initiatives that includes the socioeconomic vulnerability of the population, that also includes often the different languages that the different population uses in between the hosting community and the refugee community. It also has the element of displacement and the mobility. I know, I remember in the previous section we also touched upon a little bit on that how the capacity building could be sustained when the population is mobile. So in general, I would also like to mention the other question that was asked before regarding the legal and policy element, which I think for displaced population is often a challenge when it comes into the application for the nationals or the hosting community only. So we would often see that this population is excluded because they don't fit into this legal or policy criteria itself. In the remote areas, we also have challenges related to the securities, related to the technologies which are disrupted. So for the modality of the capacity building initiatives, those elements also need to be taken into account so that it could be customized. If I could quote that particular word, is important to fit it to the need of the population of this particular context. There are a lot of lessons to be learned from different regions, and at the end of the day, it is important that all the partners and actors, including the UN agencies, government, of course, NGOs, and the main stakeholder, the community, are part of all this planning and initiatives.
Thank you. Tanya, I want to build to what Dr. Sultana was discussing about the challenges. And this is something we were discussing before the panel, especially the mental health and the psychological support and the need of this and the challenges that you are facing. Could you discuss a little bit about the importance of addressing the mental health support, especially in capacity building?
Yes, absolutely. Thank you. Can everyone hear me okay? So firstly, thank you very much for inviting me. It's wonderful when mental health is included in wider conversations about health, so I'm very happy to be here. And I have quite a few challenges to share with you. I have two examples in particular. And in preparing for today, I thought about kind of three main themes of those challenges, as well as, I hope, some kind of ideas and solutions that I've come across along the way. And to flip the question a little bit, as I'm coming more from a practitioner clinical background, having come into then developing interventions that are contextually relevant, testing those interventions for effectiveness, and then finding that they're not being implemented. And so we have this wonderful evidence base, but we don't necessarily have the capacity then to deliver that, and that's how I then ended up working in capacity building. So the first question is around, to zoom out and ask, well, whose capacity are we building, and do they want their capacity built? And so a lot of my work has concentrated on participatory approaches to make sure that we're not making assumptions that this is the intervention that people want, this is the training that professionals want, and that we're really grounding our decisions around capacity building methods in the needs of professionals, the needs of organizations, and most importantly, the needs of the populations we're serving. So I have a couple of examples of where that has been challenging. Firstly, I've worked on an intervention development that included, firstly, of course, some task shifting. So we wanted this to be deliverable by non-specialists. And the idea was that we would deliver an evidence-based mental health intervention for refugee children using the telephone pre-COVID. And the major challenges in actually implementing this made the project very, very challenging, because actually we had huge dropout. And we had huge dropout because of ethics and IRB requirements and considerations that we genuinely had. We required that refugees would come to us in Zahle, in Bekaa, many miles from many of the settlements where people were living, for an in-person, the first session to be in-person. And that wiped out the majority of the people who could actually practically come to the intervention and start the telephone treatment. And so it was very important, and we really learned that lesson by using participatory approaches to understand from all of these people who had dropped out, why did they drop out, what was important to do differently, and then the capacity building organizations to use telephone treatment, which became extremely useful then during COVID, and we were able to support many organizations then to deliver evidence-based telephone treatment to children, was really very, very useful. So participatory approaches are important. The second example I would like to draw on Save the Children's work in building the competencies of the mental health workforce in the region for, for the existing workforce working as non-specialist providers, working also as specialist providers, and the great lack of competency building training programs. And so we are now developing this training, and we might make many assumptions about what that training should look like based on our own experiences as specialists and the kinds of content and knowledge, the theoretical background that you require to deliver, say, mental health treatment. But what we learned by using participatory approaches, key informant interviews, exploring it with professionals is that actually people have quite a lot of theoretical knowledge. They can get this from books, they get this from their at least undergraduate training, but what they don't have is the practical know-how. They don't know how to put this into practice. They have often never observed anybody actually doing it. They've never been observed. They have very little supervision. The supervision may be mismatched, so they don't actually have a supervisor who has experience of the intervention they've been trained in. And so actually they're kind of winging it, and they learn from experience. And in that winging it, we may be doing harm. And so what we're developing now is very much trying to listen to the professionals and making something that is very practical, that is all about role-playing, supervision, observed practice, and so on. So those are two examples of really trying to listen to the people who actually want their capacity built. The second thing is around how we actually achieve capacity building, and I think the example that Tadi shared is really a wonderful example of that. My experience has been that strong relationships, as in participatory approaches, are just as important in capacity building, that for sustainability and some of the issues that you raised around keeping the momentum after the kind of glamorous side of capacity building, the training and the refreshments and the travel and so on, has died out. To maintain that, what works is relationships, and long-term relationships. Building that through the projects means that we're going to get meaningful capacity building that lasts longer than the project end and when funding runs out. So I think that's a really important part of the process. And my last question is about how do we then strengthen that sustainability moving forward. So relationships are very important, but I also think we need to, and I have my researcher hat here, we need to use implementation science to do that. I think others have touched on this word before today, but using implementation science to really make sure that what we're doing is based on evidence and evidence-based experiences. So we're testing, well, how best do we build the capacity? How best do we integrate our learning into existing infrastructures, into existing systems, so that we create longer-term change, that this capacity building is integrated into what already exists, rather than petering out over time. And we can use implementation science to do that beyond just testing for effectiveness, but testing for effective implementation.
Thank you, Dr. Boski. Dr. Simona, Dr. Boski was discussing the importance of designing capacity building, especially in fragile environment. Based on your expertise in capacity building and community empowerment, how do you ensure that capacity building initiatives are inclusive and accessible to diverse populations?
Thank you, Tanya, and I'll probably build a lot on the other Tanya, so thank you both Tanyas. And first of all, good morning, bonjour, sabah al-khair also from me. I'm connecting from Germany today. And maybe if you allow me to just say 2 words about UNSSC and who we are, because not everybody in the audience might be aware of us. We're the learning and training institution of the UN system. And as such, we mainly work with colleagues from the UN across all United Nations systems organizations. We do have a track record in working with WHO, and in particular with WHO EMRO, the Office for the Eastern Mediterranean, and I'll be quoting a few examples later on from that work. We have our main campus in Turin in Italy, with another office in Bonn, and soon one in Madrid, Spain. But we actually intervene everywhere in the world wherever it is necessary, wherever our counterparts are sitting. We have around 44,000 annual beneficiaries and deliver trainings online and face-to-face. When we talk about training, we mainly work with multipliers in the system. So it could be leaders in the World Health Organization or in other UN entities, or multipliers in the wider sense of the world. So not necessarily with communities themselves. So some of the examples I'll be giving also come from my previous experience working in a global NGO. So that's just to situate a little bit where I'm coming from in terms of my work. And then to answer your question in terms of why is it necessary to think of accessibility and inclusion in capacity building, I'm probably going to echo a lot of the things that Dr. Bosky just mentioned, because what we've also learned is that exactly when we talk about capacity development initiatives, it's not necessarily about conveying knowledge about a certain subject. Obviously, knowledge will always be part of it, and while a lot of times the requests we received are framed around the knowledge that is supposedly lacking, about the gaps in knowledge that need to be filled, we usually take a step back to try to understand what is really the need that we're trying to address. And I think my first point is therefore to really spend time to understand the situation, the context. Usually, somebody comes to us and describes the situation and comes with an ask. And we usually then say, let's take a bit of time to unpack what really sits behind that ask. So we try to use systems thinking. We try to really ask, what is the situation we're trying to address? And we even sometimes come to the conclusion to say, maybe a training is not the answer. Maybe what you're trying maybe what you need is not capacity development. So let's not jump to the assumption immediately that capacity development is the answer, but let's try to understand the wider setting first. Secondly, when we do come to the conclusion that there is a need for capacity development, then again, like Tanya just said, whose capacities are we building? And are these people ready, willing, and able to have their capacity built and to act? And so this is where we always ask ourselves, what do we want the people in question to know, feel, and do differently at the end of this training? And that leads us to exercises in design thinking to really understand the audience, to really ask about who they are, what motivates them, what's in it for them. Sometimes, again, it's not the acquisition of knowledge only. It might be the certificate that it leads to that carries a certain prestige that might help in terms of career advancement. There might be pressure from within their organizations, and they need to be seen in having completed certain training. How intrinsic is the motivation? How extrinsic is it? Are there any power relations or constraints we need to be aware of? And various speakers have mentioned, is there a difficulty in physically accessing the location? Are there other constraints that make it difficult for people to participate? Are there financial constraints involved? What other priorities might they have, but also what values and norms guide their engagement? And unless we understand all of that, we won't be able to design a training that actually is inclusive and is accessible. And then once we've well defined who the audience is and what drives them, we then unpack what that means for the way we deliver the substance, for the way we frame and deliver the training itself. So this is when we start thinking of, and in fact, we're always guided by the motto, form follows function. Sometimes, again, people come to us and say, I would like a 5-day training face-to-face from to doing this and this, because maybe they heard that this is something we've done somewhere, or maybe this is how they imagined it themselves. But we might end up with a training that is online over 2 months, because at the end of the day, it turns out that something that can be digested over a longer period of time, that is easier to access, might be more appropriate. So this is where we then decide about online, offline, condense over a longer period of time, various check-in points. Should it be low tech? Should we? What are the physical constraints people have? Are there different time zones involved? How much time can people actually dedicate? How likely are they to read long texts in between? How important is the relationship in the network for them? It turns out that in many trainings, what people really are looking for is the ability to share experiences, the ability to find out how others are doing something, or how a reality plays out in someone else's context. In that case, it is as important that people receive input as it is for them to be able to share. And again, how do you build that in? Also, you need to recognize their knowledge and expertise, because it's a fundamental part also of their motivation to have a platform to be able to share and also to then unpack and learn from their own experience. So it's really all about the ownership and the relationships and designing a format that is built based on the needs and on the specific situation of the people in question. Let me stop here for the first round.
Thank you, Simona. I'm going to ask a follow-up question to your discussion. So whenever you are designing, there is a need for stakeholder engagement. So how do you, whenever you're designing, you're collaborating in capacity building, how do you ensure a successful stakeholder engagement in the programs, and how are these collaborations contributing to sustainable outcomes?
Thank you, Tanya. Well, in terms of successful stakeholder engagement, essentially what we do is really try to identify, first of all, who the stakeholders are. And again, it comes back to identifying initially what the situation is that we're looking at and trying to understand who are the actors who are either influenced by the situation in question or influencing that situation. Now, in terms of UNSCC, usually we are not the ones at country level who would entirely design, who should be involved. Typically, our counterpart, and maybe I can give you a few examples here, our counterparts would be, as I said earlier, usually a UN entity, and then together with the UN entity, governmental actors or civil society actors. I can give you quickly two examples, both from the MENA region. One is the training that we conducted with WHO Morocco, which was called Champions for Multisectoral SDG Leadership, which was specifically focusing on health professionals in Morocco, but also professionals from other ministries and other sectors. And interestingly, this was a training that was initially, again, supposed to be face-to-face in a short period of time. The idea was for a group of health leaders in Morocco to actually physically come to another country, and we had been discussing various other countries that could be of interest, to see examples of health leadership and be inspired by that, and then discuss how that could be implemented in country. Now, this was just pre-pandemic, and it became quickly clear that this wasn't going to be possible. And in fact, from the very beginning, we had been saying, in any case, this could be imagined in different ways. And there was initially a lot of resistance because there had been another program face-to-face that one of the promoters of the program had witnessed, which is why the idea came to do something similar, because it was like, we've seen this, we'd like to do something similar. And it was very hard to say, look, but we could be doing something completely different. But then the pandemic actually forced us to rethink entirely how we would do it. And in the end, it turned into a 3-week online program for around 50 health leaders in the Moroccan context, with various online modules and what we called virtual classrooms, which were very interactive. So you had 2 virtual classrooms every week over a 3-week period. Learners had to go through different online modules. They had to, and then there was a debrief after 2 months to see to what extent learners had implemented the things that they discussed. And there was a parallel leadership journey to essentially have coaching for the participants. And the way the stakeholders were identified in the very beginning, just to come back to your question, was really to see, okay, who are promoters, and this was about health in all policies and health in the context of SDG 3+, meaning how health is connected to other topics. So it became clear very quickly that it wasn't sufficient to just train health professionals, but to really bring in participants from other sectors so that the conversation about trade-offs and synergies could meaningfully happen. It was equally important to combine people from within the UN system with participants who were identified through the Ministry of Health, and then again looking at ensuring representation across different sectors. So the question on how to include the stakeholders is really starting from this initial mapping of who has a stake, who needs to be involved in the discussion, And what do we want to happen as a result of this training? And who needs to hear it or who needs to be engaged in that conversation? And just the last point on this, one issue we always spend a lot of effort is really that final debrief with a kind of a roadmap and plan of action. Again, capacity building is not just for an individual to know more or to do things differently. Capacity building is about the ability to then act differently, to implement what was discussed. And we just heard it from Dr. Boschi as well. You know, how likely will people be to actually do things differently? To what extent will we have strengthened their network? To what extent will the relations be strengthened? So the question of who needs to be engaged from the start and in what capacity is crucial in that regard. Let me stop.
Thank you, Dr. Simona. Dr. Sultana, to build on what Simona was saying, can you share examples of successful collaboration in capacity building between UNHCR and other stakeholders? And how do you think these partnerships can enhance the effectiveness of interventions?
Thank you for the question, and thanks to all for the interesting discussions. I also feel that during the various initiatives we have been having in terms of capacity building and fragile situations, we often do not get the engagement of the academia, but it is mostly the humanitarian actors and the others. So it's a good opportunity that we are engaging with all the stakeholders in order for us to see that how best we can learn the lessons and get exchange the experiences from each other. There are many examples, despite we had many challenges. But today what I would like to mention about is a project that we had an engagement with a social enterprise in terms of capacity building in the refugee settings in 13 countries across the globe. For example, Algeria, Jordan, Rwanda, Ethiopia, DRC Congo, Bangladesh, among others, were included in this project in order to strengthen the primary healthcare capacities in order to address the need for non-communicable diseases. Many of you know that during the emergencies, this has often been ignored because the focus is mostly on emergency health situation, including the communicable disease. So in order to address that, we all also know that if it is not, the diagnosis, screening is not addressed properly at the primary healthcare level, it would eventually increase the mortality and morbidity, which would eventually end up with having a high number of cases in the hospital. So I think this is one of the examples that could be relevant to Lebanon as well, considering what we see in the context, because now many people are going to seek healthcare at primary healthcare facilities, which was quite different a couple of years before the financial crisis, where the first contact for healthcare was hospital straight. Again, to give the example from this collaboration with the enterprise, we had trained the health staff who are located in the remote areas. Not necessarily they are the specialists. They have a general medical background, but the objective was to try to see that how the task shifting could be enhanced, knowing that we would have to rely on them in order to have the primary contact with the patient so that they are diagnosed and screened earlier than it becomes a complication. There was other training of trainers rolled out, and the idea was to also cascade this training to the other team members. At the same time, there was parallel capacity building initiative was initiated for the community health workers, because again, in many locations, the patients would not seek care in the health center, but they might consult their community member if they are feeling unwell. So how best to inform the community health workers with some basic symptoms, so that if someone informs, about these symptoms, they can guide them to seek care to the nearest health post or clinic, as we would call them. So in that way, the community health workers also felt empowered that they are learning something new. Some of them, they had medical background, not specialized, but they were not able to apply them. So when they receive such capacity building initiatives, they feel empowered, engaged to do more for their community. At the same time, from the community, they also have trust on their community member than going to a facility who they might not know. So we build on these elements, and the capacity building initiatives or trainings were conducted for these both groups so that they complement each other. At the same time, there was also the monitoring evaluation tool was developed. I know that this is an interest for all of us to try to see how these initiatives end up in terms of sustainability. One mechanism we try to build upon is that how, knowing that there is always a high turnover of the staff in these locations, but with the engagement of the Ministry of Health and their provincial teams, to include them in these training initiatives, the knowledge and the skill remains there. So even if there is a turnover, they would be able to train the newcomers as they have learned. We also left them with all the materials so that they could revisit them. They could also orient the new staff when it comes. So in general, in terms of, I mean, there are things that could be controlled through the capacity building, but we know there are other elements that are beyond the capacity building. So that comes with the weakness in the health system. For example, the availability of simple equipment that could help identify those diseases, or the medicine to be available, which I think somehow again relate to now what we are facing as a challenge in Lebanon. So it would go line by line, together with the capacity building, that how the advocacy through the stakeholders who are involved could help strengthen building the health system together with the capacity building of the various level of the community health staff and the community leaders in order to keep the momentum and pass through the knowledge and the skill that could be more practical and flexible in terms of contextualize in an approach, and remain in the community. That would be the benefit for everybody. So this is an example. You may also can reach out to this paper, which we also developed with the social enterprise as a lesson learned on how delivery of non-communicable disease could be strengthened in the fragile situation in terms of relying on some mechanisms together with capacity building and advocating in strengthening the national health system. Thanks.
Thank you, Dr. Sultana. Dr. Rashidian, Dr. Sultana was stressing or discussing the challenges faced whenever we are working with capacity building in the global health. One of the challenges or one of the discussions that we always have are the financial and resource mobilization. So what challenges do you face in mobilizing resources for capacity development, and how do you ensure equitable access to these resources?
Hello, and it's a pleasure to be with you. Assalamu alaikum, sabah al-khair, bonjour. So I'm grateful to the Global Health Institute for the invitation and AUB, and I had wished to be with you in person, so unfortunately it did not become possible. The discussion so far, actually, Tanya, if there is time, I would like also to have reflections on the previous questions you asked, but I start from the specific question about financing and resources. So the work that WHO does, obviously WHO is not a sort of per se capacity building institution, but a lot of the work that WHO does is involving capacity building. And in our capacity building, we focus on public institutions that are responsible for provision of the services there. And then for the same concept would be that knowing that, for example, the capacity required in the countries is quite big, and the number of people involved in that is continuous, especially if you think of especially many ministries of health in our region, they face turnover of the staff quite frequently, changes in the structures that happen very often, and then we think of the fragile situation. Suddenly you may end up with a country that has established capacities over years, then those capacities might be lost in a very short period of time to a very major extent. I mean, what we observe is that the countries in fragile settings are also resilient, and many of those things return, but those return might be taking time and effort. So in a way, the financing becomes also a major challenge there. So let me tell you some examples of, for example, how the program works. So in my areas of responsibility, and let's say related to evidence to policy, digital health, data, etc. So there are certain functions we realize the capacity in the countries may not be ideal, or new processes are coming forward that requires further sort of consolidation of those. In addition to that, some of the capacity buildings that WHO does, I think in a way it's similar to example that from the UN Center we heard, is not just about transferring capacities, actually bringing the players together and putting them in an environment that can work more closely with each other and taking that forward. If you want to conduct those programs, then the issue of financing every event would be quite costly. And within the programs of WHO, we rely on the partnership we do, and also as well as the resources that we generate in the program. So let's say with UNICEF a few years ago, we had a joint program conducted in Jordan for the data capacity related to analyzing mortality data in the countries. And WHO supported the Ministry of Health groups, and UNICEF supported the statistical center groups. So in a way, we managed to bring, first of all, having the convening of those two major partners in the country together to one event, but then also having the two UN agencies becoming very closer to each other on those fronts. The other thing that is really important, and I would like to focus on that one from the perspective of our experience in the region. Let's say on evidence to policy, since 2019, the program has been expanding rapidly in the region, and WHO is leading that agenda. We have a resolution that requested a lot of capacity building in terms of those programs in all countries of the region. Obviously, this cannot be done by WHO only, and also there are institutions in the region, including, for example, AUB and other institutions in several other countries that are strong in those capacities that can be provided for the others. A network of institutions was established in the region. We call it the Network of Evidence and Data to Policy. And this network actually, first of all, provides a platform for several capacity buildings that have been conducted since 2020. Many of them are online. So a program that is required, all the institutions come together, and then those capacity buildings are provided. The second thing is that through the network, we also provided an online platform that for all areas of evidence to policy processes, if there is anything available by anyone, any institution that is providing those capacities, which is available online free of charge, we provided a map that actually everybody can go to that website, which is publicly available on the WHO EMRO website. Go to that website, let's say that I need capacity building in this area, let's say in policy dialogue. They click on policy dialogue, they see a list of 5 institutions that they provide this. And for example, videos are there, the training is there, material is there. And this is much, much bigger than what can be done in the rounds that we do. And that's the recognition of the challenges that we have. The other issue that is a justification and also a reason for those, resource generation that we require for capacity building is that what would be the impact of that? I mean, what benefit we wish to see from the outcomes? And but by that time, actually use the question that Dr. Busky started with. I mean, whose capacity we are talking about? So in a lot of our experience is that we are talking about the capacity, our focus. We are dealing with individuals, but the capacity intention is institution. not the person itself. And for us, the main impact is that whether the institution outcomes become better. Let's say, going again to the example of data, what we are talking about is that, let's say, most of the countries of the region, unfortunately, the reporting on mortality data is not really good quality. By that, the timing of reporting may not be adequate, but the cause of death may not be well recorded. So, which is the main basis for almost every other indicator we have in health area that is of importance for the public health. So when we are dealing with those capacity building, for us is that to looking at whether that improvement we can observe in the main outcome that was intended for that purpose. If it is going for, let's say, evidence-informed policy making, then we are talking about processes. Let's say policy dialogue processes. We are talking about let's say, development of policy briefs, and then use of those in decision making. And that's what we are tracking, is that saying that how many policies are actually using these resources, how they take them forward. And individually, for specific areas, it might be also possible to track them, to make them more specific and become more granulated, to assess the specific impact, on focusing, let's say, the effectiveness of intervention itself, which is linked with the capacity building. But then that's a costly process that may not be possible all the time. So the argument becomes, you have evidence that shows certain program, if it's done properly, is going to be effective in certain immediate outcomes. Then you rely on that evidence, you apply the approach, and then you look at the ultimate outcome to see whether that ultimate outcome is being increased. And showing that ultimate outcome is actually the thing that would generate also more financing resources, in a way, in the sort of the capacity to take that forward. And lastly, in terms of resources, the main issue becomes academic institutions. Obviously, we have some strong academic institutions in the region that are doing excellent job. But at the same time, and I'm sure Dr. Nusur will be in the same page on what I'm going to say. When we need to have strong people, let's say, with capacity for field epidemiology, larger scale at the regional level, it's not easy to find those people. If you are thinking of clinical epidemiology, it's not easy to find those people. And these are areas that actually many universities in the region train people in these areas. Then if you go to other areas that many universities actually are not investing enough in them in our region, let's say informatics, health informatics. So the schools that are strong in health informatics are actually few in our region. Health economics, then actually the problem becomes bigger. So when we are talking about resources for capacity, we also need to think of what are the academic resources for those processes. So the disciplines should also grow, become enhanced, and do a better job, while we are doing also programmatic things, which is the job of WHO and then the institution and other institutions that come forward, and especially the things that you might do in the Global Health Institute for your capacity building. So I stop here and then follow with other questions.
Thank you, Dr. Rashidian. Dr. Nusur, actually, I want to hear, or if you can share with us your success stories and lessons learned from past capacity building initiatives within the Eastern Mediterranean region. You're muted. Dr. Nusur, you're muted. Yeah.
Yes, ma'am. Thank you. So, okay. Just for financing issue, if you allow me to reflect on what Dr. Rashidian. I think the financing, it's not only the responsibility of UN or the international communities. It has to come from the countries as well. The country should realize the importance of the health workforce. The health workforce are contributing in 3 major goals of sustainable development goals. It's not only health, equity, education, and workforce. So we have 4. This is very important. So we need the country to take the lead of this efforts and to make sure that they are really investing in this. So far in the region, it's more toward being clinicists and and investing in more infrastructures in terms of buildings, equipment, and other things. I think this is the major challenge that we are facing. We do not expect, to be perfect during the emergency situation if our systems are suffering from major problems even before having the emergencies. So the emergencies, it's a reflection of the current situation of our health system. This is one. And this is very important. That's why we keep, the sustainability. I always keep talking about the sustainability because the external fund, it will not sustain any efforts. However, the sustainability comes by, encouraging the governments, the countries to invest as, national plan for that. So back, to a few things that the real investment, in health workforce development, it's not only financial resources. Financial resources is very important aspect of that. However, let us talk about, for example, having jobs for the graduates, how we can offer, jobs for our graduates from the universities. This is one, or the academia. Secondly, we do not have so far at the international, regional, and in-country level the classification for health work capacity workforce. So we do not have a classification. And this is very weird, and this is very critical. So we need to classify what we mean by epidemiologists, what we mean by nutritionists, what we mean by workforce, frontliners, what we mean. These things should be standardized. This is, what we need to focus on standardization rather than just the curriculum standardization. Thirdly, I think, path career is not clear. This is very important to attract, the best to be part of public health or health workforce has to have, to help them in building their own career path or, career path in general. Unfortunately, although it's not costly, but in our region, we are lagging behind and we do not have such a definition or a clear roadmap for our workforce capacity. Moving forward also, we have to admit that there is a gap between academia and, the real needs from the countries or from the ministries and sometimes. And here, I would like to talk also to stress that, as colleague mentioned, it's not health only. It's nowadays we are talking about climate change is one health. So we have 3, 4, 6 ministries are involved in the health workforce capacity. So this is also, we need to bridge the gap between academia and how we can do this to be practical. I think, in job training, hands-on training approach has to be more applied in our academia and in general, training or certified or whatever. So we need also to work on that aspect as well. So it's very comprehensive approach. So the success always there are many challenges, but also, we should not forget about the opportunities. And I think, with all the suffer that we are witnessing during COVID-19, but it was very clear that the country start relying on themselves more and believes on the importance of public health. So we need to capitalize on that aspects and how we can make the use of better serving, building the workforce capacity. Especially we are, again, the complexity of our region should be considered. Nowadays, as I remember, even before COVID-19, there was an Ebola outbreak, in Africa, as colleague mentioned, Africa area is part of this work. So the Ebola outbreak showed the world that we are not ready. We could not find, I am talking here at the global level, and back to our region, but it was obvious and that we are not ready at the global level to respond to such a challenge. And it's not only communicable disease, many challenges that we are witnessing, in terms of, like we see the complexity of emergency now in sector Gaza, for example. It's not only emergency, it's not communicable disease, it's more complex situation. So what I am saying that we are lacking for database. and we are lacking for, a roster of experts who can help us during the emergency. We even do not have, a clear, description or organogram or something about where these people that we are train them and how we can utilize them during the emergencies and in terms of rapid response others. One of the things that I think it's success story from the region, it's as colleagues mentioned about the importance of community health engagement, community health, and this is, important strategy that we need to focus on. And I am bringing examples from countries that really they did excellent job, like Pakistan, Afghanistan, Yemen, with lady workforce programs and trainings, all these things that were very, very effective in service delivery based on their training, specific training. I think, Dr. Rushdin raised very, very critical point, which is related to be specific or specialized, or this specific disciplines. Nowadays, we cannot talk about public health as 30, 40 years ago. And this is what's going on in the region. We are talking only about public health. So you can imagine the public health officer or a professional, he has or she has to be specialized in antimicrobial resistance, then in non-communicable disease, later in mental health, and later, in environmental health, etc. So it's time, to come a discipline, very clear discipline for public health. So while we have, for example, general surgeon, and then we have a specific surgeon for heart, specific surgeon for brain and others, So this was critical. When we pushed our public health professionals to be the focal points for antimicrobial resistance or infection control in the hospitals, we saw the majority, not the majority, but a significant number of this among our colleagues, because they are not highly trained in specific area or a specific discipline. So sometimes what we are doing is a generic training. Nowadays, we have to be focused. And we have to be, having clear disciplines, for example, for non-communicable disease, for mental health, for polio and immunization, for communicable disease and others. The public health professional cannot be anymore everywhere and for every task required. If we need to improve this specialty and we look. The culture in the region, it was started to change. Many of the countries were relying mainly on the doctors to do everything. Nowadays we are trying and we are seeing some changes in the mentality and in the culture, to engage others and to work under multidisciplinary approach. This is very important. If we need to do significant achievement and movement in our region, we have to engage others. It's not only one man show or one doctor show, etc. I am a doctor, so I have no sensitivity about this, but we cannot keep saying that we can do everything. We have to engage lab, we have to engage vet, we have to engage nurses, nutritionists, and other colleagues. So especially we are witnessing, communicable disease, 2/3 of what we are witnessing over the world is coming from emerging zoonotic disease. So we have the vet and we have to work with the lab also. So I think I claim that FETP program, Field Community Training Program, is a success story because for certain reasons, I remember, in 2009, we started with 3 programs in the region, Jordan, Egypt, and Pakistan, as we are working with the Eastern Mediterranean region. But nowadays we have this program in 16 countries from the region, and it's become very important to focus on the in-country and in government. I do not want to go in more details, but again, the in-country capacity and sustainability, it's very important to make these efforts sustainable and achievable later on.
Thank you.
Thank you.
Thank you, Dr. Nsour. As a final question for the panel today, there was lots of questions during the presentations about monitoring and evaluation. And this is where I would like to hear the point of view of Dr. Rashidian and Dr. Bosky on really the importance of measuring and evaluating impact for sustainability, and how do we work to translate evidence produced by research into M&E efforts. So maybe Dr. Rashidian, you would start, and then we will end with Dr. Bosky.
Many thanks indeed. You raised two important aspects in your question. One is about sort of how to ensure that evidence generated from evaluations are being used for decision making. The other one is that whether the capacity building programs are making the effects that they have. And both of them have a lot of, I would say, peculiarities and specificities that should be considered. When we talk of ensuring the evidence generated being used, there are 2-3 maybe key dimensions that I would like to highlight. So when we are talking about the sort of evidence generated from decisions and capacity to use those better, we are talking about identifying the key challenges, being able to identify the priorities for those key challenges and deciding to address those priorities for action. Most of the time, the evidence we are talking about would be the national evidence. And when we talk about national evidence for such purposes, then obviously you need to have the capacity in the country to generate good data, to have a sort of those resources to analyze them properly, to sort of categorize them very well. Then the question becomes, then what interventions you want to select for addressing those? Then in the selection of intervention, there are the issues related to effectiveness of those interventions. That evidence could come from anywhere in the world, whether that would be feasible to conduct in the country, whether that would be sustainable. If you do it today, a policymaker usually, when they think correctly about the process, they don't think about, I'm doing this because tomorrow I want to see effect. Is that if I do it today, is it going to stay and continue as an effective program? So then all of those also, they require their own areas. And then one key piece of evidence that helps the country itself, but other countries, is that when a policy has been implemented in a country, whether that policy has resulted in the effects that required, and then using that evidence to transfer to decision making. And I guess some of the programs your colleagues presented this morning are related to those. Capacity to evaluate properly, to be able to measure those processes and taking that forward. So that's one element of it. And then when we are thinking of these areas, if we think of the institutional capacity development in the country, thinking of the institutions that generate the resources for those decisions, but most importantly, thinking of the resources within the ministries of health, within public institutions that make decisions so that they can absorb these processes. And then when you are doing the capacity building for those, we are talking about generating those individuals that they are capable of doing that, generating positions. One of the questions that before the break, the audience were asking was about, well, when people are well trained, so can we have the demand for those capacities to be used in the process? And part of this demand generation is also I would say if the policymakers know the importance of an issue, they actually generate the demand for it. They will find the money for it. So then it would be that the process, they knowing this is important, then obviously they become the magnet for it. And if they become the magnet, the best people actually become more attracted to them. But then going to the issue of evaluating the impact of the capacity building themselves, I referred to some of those elements earlier, so I don't want to repeat those. The issue would be that, so what was the main issue? It's one thing to talk about the immediate impact of your capacity building, which is important. I'm not discounting the value of it. But then as a sort of UN agency and a sort of public institution in the country, you are actually looking longer term, whether this is going to make the change that is required. But then in fragile setting, there are further complexities. And I'd like to highlight two examples. Just last year, a few months before the current crisis, and I mean, unimaginable occurrences we are seeing in Palestine, not only in Gaza, but also in West Bank, I mean, everywhere in Palestine. So we had a capacity building event, policymakers from ministries of health from the West Bank part and also from the sort of Gaza part, they were all there in Cairo. Capacity building for evidence-informed policymaking and health system aspects. 1 week of, I mean, brilliant discussion, questions were asked, capacity and the experiences being shared. Then, I mean, I keep praying, saying that those people are still healthy, and keep praying that in future, that those capacities can be regenerated. And we know those capacities are not just about individuals, it's also institutions. And in crisis, institutions are also damaged dramatically. So when we talk about also the longer term effect of those capacities, we need to think of what do we mean by that in sort of fragile context? What do we mean by that during the emergency? Similar example I can give about Sudan case, which is again another major current emergency in our region. So I mean, WHO worked very closely with Sudan in enhancing the capacity of National Public Health Institute, with sort of those resources, structure, etc. Many of those capacities and human resources have left the country or are not in place anymore. So again, the issue becomes, so if I want to see an impact remaining in the country, how to link that with the sort of other processes and making that possible. And lastly, the issue becomes, again, at the case of Sudan, because a former Minister of Health of Sudan, when I had the pleasure of meeting him and alongside our former Director of Health System, we were together in the country, and we were talking to him about their needs for human resources. And he said, I have a big challenge. As soon as I improve the quality of my academic trainings, the people who are trained leave the country because they are better absorbed outside. Again, on low resource setting, if you don't think of the part of institutional demand for those people to keep them there, keep them sort of satisfied for their needs so that they serve the country, that's also part of it. And all of these, I mean, what I want to say is that our regional director, WHO, Dr. Hanan Balkhi, she's starting a flagship program focus. I mean, she has selected 3 areas. One of them is enhancing capacity of human workforce in the region. And I'm hoping with that we will actually generate more resources, more demand from institutions like yours, and also more resources globally so that the major gaps in human resources can be better addressed in countries of the region.
Thank you. Tanya.
Thank you. I'll just briefly add to that. I agree with all that was said, and I maybe will answer more from the academic side, put the academic hat on. One of the big issues that we have is that there's a huge publication bias. And so we see all the best practice, all the things that worked really well when we've done many, many systematic reviews and we look at, for example, effectiveness, and we want to include maybe indicators of acceptability, of scalability, of implementation, feasibility, and these kinds of things. We find very, very little. And that's because we don't like to report our failures. We don't want to publish our failures. And if we do, often we get knocked back by journals who don't want to publish them either. And so we end up with this huge publication bias. And actually, there's a huge amount of data out there, not necessarily accessible right now, of these failures. And we learn so much from these failures. Certainly, I have in my career learned more from the things that I didn't manage, and I can then improve. And so we recently did a review. We were building a family intervention for adolescents here in Lebanon, contextually relevant, grassroots, but we wanted to learn from the experiences of others, and we just couldn't find much data. And so we used a systematic review to contact authors, clinicians, practitioners, organizations who had been delivering this, and got a wealth of data on all the things that went wrong, that were challenging, that were difficult, ideas they had tried. And this then helped us to preempt, and quite rightly, a lot of the challenges that we then experienced in trying to implement the intervention and to scale it up as well. So I think a lot of the data is already there. We tend as academics to want to just get more data, but a lot of it is there. There's just, unfortunately, this publication bias that we need to try to overcome and swallow our egos a little bit. And then secondly, to really listen to that data and what families in particular are saying, what our target populations are saying, what professionals are saying who are frontline with all of this wealth of experience. And this can lead to innovation from very much the grassroots up, rather than coming up with our kind of own ideas, relying on AI, but really listening to what people have experienced on the front line. And I wanted to just share a very quick example of how we're attempting to do this with our family intervention for adolescents here in Lebanon. That we're getting funding in order to be able to do some capacity building, training of trainers and training of facilitators and so on. So we build the capacity of organizations to deliver this intervention. And we'll do this all at no cost, of course. But the payoff is that we need to integrate the system to improve quality, to monitor those challenges in a very open way, that we are accepting criticism and difficulties and challenges and areas where perhaps in Lebanon, in other regions, it's not as contextually relevant. So the payoff is that we want to have this kind of very much hands-on supervision and observation of delivery, and to get feedback on that, and for that data to be shared with us so that we can improve our implementation over time. Thank you.
Thank you very much. So I think we have 10 minutes for Q&A. Yeah, that's it. Yeah. So if you have questions.
Thank you so much. And I would like to return to Dr. Nassour's point regarding that the people are being trained and their capacities are being built. They are not being trained on very specific areas. And I want to thank him for raising this topic, because this is very important. I actually have encountered this a lot within my work on RCCE, within the Lebanese context. I believe that things are changing. Maybe they're being trained more on RCCE, community engagement, things that are more specific, but work is still needed to be done, of course. On the other part, I'd like to share my experience, brief experience, on specific locations within the African region, and specifically on countries that are very much rich with experiences in SBC, RCCE, because as we all know, within the Africa context, there's a lot of pandemics, outbreaks that are always emerging, so they always need to be trained and ready. So I work on epidemic management, and I have witnessed that when we have a lack of coordination between certain implementing partners, UN organizations, on training the healthcare workers, the frontliners, and each organization is trying to push its own, let's say, agenda. I know it's a bit negative, but what they are currently advocating for as a theme of training, things get a bit confusing for the trainees. So we have several things that we work on that we want to train the health workers on: infodemic management, social listening, RCC, risk communication, community engagement alone, feedback mechanisms. So we always get the feedback from the people who are being trained that there's a lot of confusion. They ask us, so what's the difference between social listening conducted by infodemic managers and social listening that is conducted by healthcare workers? So my recommendation, my wish actually, because it will make my work much better, it's whenever we have a new emerging training theme, whenever we have a new emerging study that people want to train the frontliners on, the ideal way is to have something that is more standardized. Even with the themes that are mostly, they look alike, they have common terminologies, it will be great if we can really merge all of these learnings and make it less confusing for people in the field. Thank you so much.
Thank you. We'll take another question. I think we're done. Okay. Thank you, everyone. Thank you for the panelists. And I think we have a break. Yes. Thank you.
Yeah.
Thank you, everyone.
Thank you.
Thank you, everyone. Thank you, Dr. Nsour, Dr. Rashidian, Dr. Simona, Dr. Boski, and Dr. Zinia. Thank you for joining us today. And Please feel free to network outside, and we hope to see you again in our future events. Thank you very much.
Thank you very much.
Thank you. Bye-bye.
Thank you.